Welcome to Cardiovascular Matters. Whether you are looking for answers for yourself or someone you love, we are here to give you the best information available. Each week, the founder of Cardiovascular Institute of the South, Dr. Craig Walker, and medical device sales veteran Terry Roberts discuss the causes, symptoms, treatment, and prevention of health-related issues stemming from cardiovascular disease. Now here's your hosts, Dr. Craig Walker and Terry Roberts.
Hello, everyone. Welcome back to Cardiovascular Matters. I want to thank everyone for listening to the podcast, and I also want to remind you that you can subscribe for free. All you got to do is click the button on the screen, the device you're listening to, and subscriptions are free. So be sure and subscribe. That way you get notification when new episodes drop. Last episode, we were talking about when to go in and get a cardiovascular screen or workup in just with your provider, and in that discussion, we talked about small vessel disease, and we're talking about the vessels, the vasculature in the heart, and this tends to affect women more than men, but it can affect both. And we wanted to spend some time today talking about this issue because it can be a real problem, and it's often not diagnosed. So, Dr. Walker, please walk us through what you wanted to present on small vessel disease with women and also some men.
Sure. So, Terry, small vessel disease is an entity that really was poorly understood, and really within the last decade has really become something that we know a lot more about. So the American Heart Association has even created something called a Daisy Questionnaire.
Okay.
Many women were coming in to see cardiologists in particular, but men as well, who had fairly typical symptoms. When they would exert themselves, they would have chest pain, or when they would become emotionally upset, they would develop chest pain. And often these patients would go through a workup. The treadmill may not show very much. And they might even have an angiogram. And the coronary arteries that we could see on angiography were normal.
They look normal.
And they were told, look, there's nothing wrong with your heart. Everything's okay. Well, but yet some of these people were going on later on with normal arteries by angiography to have heart attacks. And so the thought was, what is this? And ultimately it became obvious something else was going on. Now, let me start by saying all the arteries of the heart are small. So when we say small vessel disease, what we're really talking about are those vessels that are so small, we don't see them when we do an angiogram under normal circumstances.
Right.
And some of this has to do with vasoregulation, but some of this has to do with obstruction of those arteries. Now, arteries everywhere in our body are much like a tree. A tree has a big trunk, then it has major branches. Off of those come smaller branches, then come yet smaller branches until we get all the way out to the twigs. I'm speaking here of the twigs before you get to the leaves, the little tiny branches that we cannot see angiographically. Now, when those become diseased, what happens is they choke off the flow of blood. So the flow of blood is slower. Now, in the process of atherosclerosis, what we have is a slow buildup of what we call plaque. And plaque is made up of all sorts of things. It has fat. Here, this fat starts to accumulate in the vessel wall. Then ultimately, it sort of pops, almost like a pimple might pop when it has material inside of it. It pops, and we call that ulceration. And blood is passing by, and the blood wants to heal that. So a little bit clot starts to occur on that. And that's how calcium gets incorporated into the vessel. It's a healing process whenever we have a rupture of some of these early plaques. Now, of course, if that clot that occurs doesn't just heal that area, but rather shuts down the whole vessel, that's when we have a heart attack. Okay, and that's particularly problematic. Now, in small vessel disease, the problem is that you're slowing the flow of blood in that artery. So now if we ulcerate a plaque and the clot starts to occur, in the face of slow-moving blood, that clot is much more likely to become occlusive in the vessel. And this is why we believe that women, even with much less artery disease shown in the vessels that we could see angiographically, were dying of heart attacks. And so we looked for how could we make this diagnosis. And early on, the way that this was made was invasively. We would get into the coronary arteries, we would put flow wires down, and we could absolutely assess flow. And we'd go through a series of tests, but that's invasive. That carries a certain amount of risk. But often we could make the diagnosis of small vessel disease. And when we find this, we could treat the patient with medicines. And these medicines would alleviate their symptoms, but also, and this is the part I think so important, also lessen the risk of going on to heart attack. So this became such an issue that the American Heart Association even created something called the Daisy Questionnaire. And it's an easy thing to look up. One would look this up, and it is a questionnaire to give us an idea of women at risk. Now, this is really particularly important because women historically thought that they really didn't have heart attacks, even though they didn't pay attention to all the other women they knew that were dying of heart attacks. They really thought they were protected against it. And in fact, most women see as their primary care physician only their OBGYN doctor, who predominantly does breast exams, checks cervical swabs, to make sure there's no cervical cancer,
Right.
and evaluates that system, but really doesn't pay attention to as much to blood pressure, cholesterol, and the other risk factors. Now, another test that later on became obvious that could diagnose small vessel disease was a test called a cardiopulmonary exercise test.
Okay.
Now, with this test, a patient pedals a bicycle and they're wearing an oxygen mask. And we're looking at what happens to the oxygen as they pedal and as they exercise. Now, this test is a little bit more difficult to do because you're wearing a mask, you're pedaling a bicycle, you're connected to an EKG all of those times. But the problem with this test is there can be some false positives, there can be some false negatives. It's a fairly subjective test as we look at this. It's certainly a very good test. It allowed us to non-invasively assess many people rather than to actually go into the heart.
Right.
But it had its limitations. I think in today's world, the very best test that I know of for developing, for determining if one has small vessel disease is a cardiac PET scan where myocardial flow reserve is calculated. Now, those are big words, but a PET scan stands for positron emission tomography. And we give an isotope to a patient via a vein, and we image the heart.
Right.
And when we look at the heart, we can see which parts of the heart are getting blood and which are not, because this isotope that we give goes where the blood supply glows. Now, what we then do is we then stimulate the heart, and we re-image after the heart is stimulated. This stimulus behaves the same way as exercise would behave. And we compare those two issues, those two views. They should look the same. They should look the same. If they don't look the same, then that's a problem. So if let's say we see an image and we see one part of the heart isn't getting good flow at rest, and it's not getting good flow with exercise, then typically that means that person has already had some damage to the heart muscle. There's some cases where if it's just starving severely, it will look the same that way. But most of the time, that means that person has already damaged the heart muscle.
Okay.
If it looks good at rest and it looks good with exercise, we call that normal. And if it looks good at the rest, but after stimulus with this medicine, it looks abnormal, then that person, we think, is having a blockage of some sort and the heart is starving for blood. Now, in addition to that, we can quantify this blood flow because these isotopes show up, and we can actually count these isotopes as we do PET scan. And so we do what's called flow reserve. And flow reserve determines our ability to increase heart blood flow with stimulus. This is a pretty painless test that tells us a lot of information, but specifically, it is, I think, the best test in evaluating for small vessel disease. Now, why is this so important? I cannot tell you how many times in my life I've seen women diagnosed as hypochondriacs because they have chest pain, pretty typical chest pain that they're worried about because they've seen others who've had problems, and yet they're treated just with nerve pills. And the treatment for this is not nerve pills. The treatment for this is how we would treat ischemia, using calcium channel blockers, beta blockers, watching this, because those things not only alleviate symptoms, but they lessen the risk of the disease process. Very, very important to do this. Same is true for men. So, when one has continued pains and they even have undergone an angiogram and the arteries are normal, people say, well, you can't really have a heart attack with that. You absolutely can. And this is something that we've really had a big problem overcoming in terms of explaining to people, because historically the angiogram was held as the gold standard. And if it was normal, go do whatever you want. Go run a marathon if you want, no issues with that. Well, that's not exactly true. That's not exactly true. And like so much of medicine, we've had to continue learning. I tell people all of the time, I've learned much more medicine post-med school than in med school. Why is that? Because it keeps changing. What we once thought was right proves to be wrong sometimes. In fact, when I was in medical school, it was considered malpractice if one gave someone who had heart failure a beta blocker drug. Now it's considered malpractice if you don't, just to give you an idea of how the evolution of thought has occurred. And it's not surprising because we learn. And it is important to constantly learn in medicine. In fact, it's what I teach young students. Enjoy learning because it's something you're going to need throughout your life as you work as a physician. And if one enjoys learning about these new things, it makes medicine and the practice of medicine so much more fun. But, I had an idea in the past that we'd put out Daisy Questionnaires just to get a feel for how common this was. I just wanted to get a feel as this was just being looked at in some of the OBGYN offices. And it was amazing how many positive responses we had of people who wanted to come in, many of whom had been told everything was fine. And in many cases, it was fine. We did not find small vessel disease. But about half of the ones where there was a positive Daisy Questionnaire actually did have small vessel disease. And actually, lo and behold, a fair percentage of those actually also had big arteries that were diseased. But, we think that, the big artery disease is clearly much, much, much more dangerous. And the answer is to that, not totally true. Not totally true. And it looks like most of the women that develop this, sometimes they develop it younger in life, but particularly over time as hormones change and things such as that. And now in men, that has not been characterized as well, because this is more prevalent in women than men. Once again, it's one of the many things that women are called hypochondriacs that actually represent big disease. And I'll tell you, Terry, as I've said before, when we did a vein study, women are actually pretty tough. They've got inner toughness. And when I'm treating veins, I'm much more apt to see a big, bulky man pass out than a woman. And, they're tough and they've been through pain. And it's interesting how this goes. And so I think whenever somebody has repeated symptoms, we don't stop just by, standard test. If someone has that, particularly a woman after a change of life, I really think evaluating for small vessel disease is important. And I cannot tell you how many women have been diagnosed, we've started on medicines and their symptoms have then gone away, who are like, Doc, this is miraculous. And, they send their friends because they may go to the beauty parlor, or they may have other things where they're speaking to women, or they might have a women's night out, you name it. And they start talking, and their friends say, I've experienced that.
Same thing, yeah.
Yeah, and I got to tell you, it's way more common than we've historically thought. And, now that we know a little bit about this disease process, I've got to tell you, I personally missed it. Traditional teaching was if you didn't see a clear defect on standard, like just a technetium scan or something like that, one of the earlier tests we did for detecting heart disease. And certainly if you had a normal angiogram, you didn't have really as much to worry. The only thing you then had to worry about was coronary spasm. That's an error. That is not true. And it's just as the field expands and as we learn more about it, we have learned how to better treat these things. And, I look to a day where we can A, prevent most heart disease, but B, treat it in earlier stages. Although I love doing angioplasty and stents, I've spent a lot of my life honing those skills.
Right.
I'd be the first to tell you the best treatment is prevention. It is number one, always best. It carries the least risk. It results in always the best results. Nature has made us into things that can do pretty good on our own if we just don't poison the system.
Right.
And it's very important for us to look at that. And that's why I think this whole focus on prevention and early care simply beats what I've spent much of my life doing. I tell you, I've treated a lot of people who come to me who already have gangrene on the peripheral space, people who come to me who've already had massive venous ulcers, people who've come to me in cardiogenic shock with no blood pressure. And we've saved many of those lives. But I've got to tell you, that's not when we should be getting to the disease. If we're going to really crack the nut of death from cardiovascular disease, the key is going to be prevention. And then if we can't prevent, early detection, where we can employ those things that lessen the risk over time. Lifestyle modification, appropriate medications, those things matter. And it's really where we have to focus as we go forward.
I love it. You bring up the point about the cardiovascular PET scan, and that technology is relatively new. It's it's making its way out into the world. But if you're a patient out there listening to this podcast, and if you feel like Dr. Walker's talking to you today about the small vessel disease, let's say you've been evaluated and things seem normal, but yet you still have these issues. If you want to be evaluated with PET scan treatment, they have that within Dr. Walker's practice. Be very easy just to get on the website at www.cardio.com, and you can be taken care of those very, very easily that way. So anyway, what an interesting topic. And, it came up again today about, it's good to get evaluated because the knowing you're either, need to be put on some medication, or knowing you're going to be fine is in itself a revelation. Worry is a terrible disease. And if you can eliminate the worry, I think you're on your way to being healthy and happy. So a great topic today.
Thank you, Terry. Yeah, I think treatment for anxiety as the primary care should never be the first care.
Right.
It should be after we're certain there's no true pathology.
What's led to that anxiety? Absolutely. Well, thank you again. And everyone, thank you for listening to Cardiovascular Matters. Again, subscriptions are free. Just click on the screen. You'll be notified when the next ones come. Thank you very much.
Thanks for listening, and please subscribe, like, and share this podcast with your friends and family. Join us next week for new topics and answers with Dr. Craig Walker and Terry Roberts on Cardiovascular Matters.